I'm a professor of orthopedic surgery at the University of Kansas. There aren't a lot of female tenure professors, especially in orthopedics. I think I was number 16, something like that, so there aren't a lot of us. But pertaining to this topic, I'm past president of our state medical board and continue to serve on the board as a representative from the governor's office. This is a topic that I really became engaged in during my time on the medical board. I had no idea that this was even an issue, especially an issue for female physicians, until you go to board meetings and you have people that come in that want to get back into practice, and this is an issue. And it's an issue that I'm passionate about, and again, I appreciate the opportunity to talk because, again, I didn't know anything about it. Maybe I just didn't listen well enough in residency. I didn't hear about it, but it never really gets discussed. More and more people are taking time off from medical practice. That's actually becoming more of the norm. It's not maybe as accepted as one would hope, but it is becoming more of the norm. And so I titled this talk sort of the on-ramps and off-ramps of your career, because there may be times when you leave your practice, but then you decide that you want to come back in, and how do you make that transition? Has anyone here taken time off of their medical practice? We have one person. We have a few people. Okay, so people have taken time off. For someone, yes. Because I realize I don't have handouts for this talk. But I can send them to you. Thank you. I appreciate that. No, it's not for this. You'll get handouts. I'm sorry about that. For those of you who have not taken time off and are still in practice, if hypothetically you would take off, say, 4 or 5 years because you're trying to raise young children, how do you go back into practice? What are the steps? Anyone have any idea how you get back in? Can you just keep your license up during the time? Okay, that's key. Yes, those are key points. Keep up your license and keep up your CME. That's critical, and I appreciate you bringing that up because that is critical and that's something that's not discussed. And so what we'll be talking about is what some of the issues are. It's for physicians who are leaving practice. Men and women seem to be leaving practice at about the same rate. Men tend to be older. Men tend to leave practice because they're going to retire. Women tend to, although the younger men that do it for other reasons, but it's primarily because they're going to retire. Women leave practice at an earlier age, usually because they're caring for children or other family members. Because they're leaving at an earlier age, once the children grow up or whatever family issue was occurring that forced them to take some time off, once that's resolved, a lot of women want to go back into practice. And so this is where it really does become a women physician issue, because we're not dealing with those that retired or had to retire or had health issues. We're talking about those who voluntarily left and then wanted to come back into practice. And so this is what's called the reentry practice of medicine, and so, or the reentry into medicine. Reentry is defined by the American Medical Association, and I'll just read this to you, as a return to clinical practice in the discipline in which one has been trained or certified following an extended period of clinical inactivity not resulting from discipline or impairment. That means that you don't have a substance abuse issue, it's not a disruptive behavior issue, so there's not an impairment issue that's forced you out of practice. It's not disciplinary, so you haven't had issues in your practice, there haven't been a lot of liability claims, not a lot of other issues. This is where you were out for a period of time that's to some degree elective, although a health issue, and it's not really elective, but it's something that you're able to choose to do. You're not being asked by a licensing body to leave practice. What's key in that definition is return to clinical practice in the discipline in which you have been trained. That's different than retraining, which was a concept that was big 15 to 20 years ago, of taking people and teaching them that are still in practice, but training them in a different area of medicine to try to fill healthcare needs or healthcare gaps. So it's not retraining. It's not remediation, where someone does have issues in practice and someone, especially a state licensing board or a hospital, may think that you need perhaps some additional training because there are just too many issues in what you're doing. This is something, again, that's fairly elective. So the definition of return to clinical practice in the discipline in which you've been trained is pretty clear in that definition. We know what that means. Where things get a little bit challenging is for an extended period of time. How long is an extended period of time? Don't know. It's pretty nebulous. We don't know what that means. And for each physician and each physician practice, that's different. What you do on a day-to-day basis, is it if you are a proceduralist or not a proceduralist, if you do procedures, if you do surgery, should you be out a shorter period of time before people have concerns about your technical skills, or are the intellectual components, the knowledge base you have, is that more important? How long can someone be out? The other part of that definition that's challenging is what describes clinical inactivity. You would think that that would be fairly obvious. It's not, and that's in a lot of statute. It's also called the active practice of medicine. You never have quite as much fun as when you're working in a room of attorneys at a state medical board trying to figure out the active practice of medicine, because they look to the physicians like we should know. I don't know, something, I don't know. I mean, and actually I apologize for being late. I was on a conference call with the board because we had a group of people, people that had applied for licenses that we were going through. One person hasn't practiced in a couple of years, except for a 4-week period of time last year when they saw 480 patients in locum tenens in another state in 4 weeks. Is that active practice? It sounds like really busy practice, but is it really the active practice of medicine? Does that allow you to see the scope of practice? I don't know. It's hard to know what that means. So when you're looking again at the extended period or the active practice, where have state medical boards stood on this? What did they say? Well, according to the AMA, about almost half, so 49 state medical boards actually have policies and regulations that look into how we get people back into the practice of medicine. So for those that are ever interested in this and you want to try to take something home and want to be empowered to do something, this is an area that needs help. Because with more and more people coming back into practice, especially women, there needs to be better definitions. So you've got 49 states, we've got one that doesn't, but at least you've got 49 state medical boards. There are more than 50 state medical boards in the country, though, because our board is a little different. We regulate everything except nursing and pharmacy. Most boards around the country are MDs and DOs and everyone else, and so there are a lot more than 50 state medical boards. So 49 is about half the number of medical boards. When you look at their policies and procedures, they have them, they're all over the map. It's anywhere from being out of the active practice or extended period of time it is defined anywhere from 12 months to 10 years. There's no consistency. The mean is about 2.8 years. Most states are somewhere around 24 to 36 months before it's thought that you are no longer in the active practice of medicine, but not really a definition, again, of what you're doing for those 24 to 36 months. And this is where I see a lot of women who are trying to get back into practice. Again, we don't discuss this nearly enough, who are trying to get their licenses back. So they've raised their children, they come in, they haven't done anything clinically for 3 or 4 years, and then they want their license back. What they're explaining to us is, I take care of my children, I diagnose my children's illnesses, I take care of my kids' friends, I give them their medicines, and this is all great and it's wonderful, but that really doesn't define the active practice of medicine, so unfortunately it doesn't count. Now, if they'd spent that time also perhaps volunteering at a free clinic somewhere, something where we can see that they've kept up their clinical skills, that's probably active practice, but again, how much? How often do you need to do it? Is 1 day a week enough? Is 1 day a month? We don't know. So this is what you're going to hear a lot of in this talk, and I'd love to engage in some discussion, is a lot of questions because we don't know. And this is a huge issue that's going to get worse until we have some definitions. Other things that are not thought of as active practice of medicine. If you leave practice because you have an administrative job that's being offered, so a hospital administrator, a practice administrator, something within a school of medicine, and you give up your clinical practice during that administrative role does not count as an active practice of medicine. We've had people who have come in who've said, I'm a dean of a medical school and I supervise what's being taught. That's great, but there's no hands-on patient contact. So they're supervising, they're not actually teaching, they're deciding what's being taught, but there's no patient contact. Hospital administrators will say, every day I'm making decisions on what occurs in this hospital and how this hospital is run. Again, there's no hands-on patient contact. They sometimes get themselves in a bind, though, when they say, well, but I review charts and I decide if, and look at specific patient issues and help with any healthcare determinations, especially if there's a question on standard of care. That's the active practice of medicine. So they can either say they're administrators and they're the financial people and they have no patient contact and therefore probably need some sort of discussion of reentry, or they're engaged in decisions about patient care and therefore they're practicing without a license. So either way, there's a problem. So that's when we just, we just look at them, it's like pick one, because either way, you're going to have a problem. Just since in a lot of states now, and in Kansas as of July, practicing without a medical license is a felony, you probably don't want to do that. So it's a problem. Yes, ma'am.
If you're in an administrative role, is there a minimum number of hours that qualify as clinical? Because you're maintaining your license, but when you apply for a license, nobody asks you how many patients you're seeing in a week.
No, this is true, and this is why this is going to be part of the core of this, is if you want to figure out if you are going to take time off, again, plan like, it's a trip, you're on a highway, you may not know the end where you're going, but at least you've got a map and you know the on-ramps and off-ramps, and that's part of it. One of the big things is to keep your license, keep up your CME. When you reapply for a license, most licensing boards don't care how many patients you see. They don't care if you've seen any patients. But so you may have a license, but then it's going to be an issue with credentialing and liability insurance, because they do care how many patients you're seeing. That's going to be coming up in a little bit to the discussion, is that licensing is not the same as the other stuff. But I appreciate that. So again, most of this when we're talking about active practice, how much we don't know. What exactly is active practice? How much is enough? Don't know, don't have any idea. And this is where we really need to come to some determination. So as was just mentioned, when to keep your license active, the vast majority of states are not going to ask if you're actually in the clinical practice of medicine. They don't care. So you can have an active license, and well, they care, but it's from a licensure standpoint, you can have an active license and not see patients. The downside of keeping an active license is it's more expensive. There are more CME requirements than what are called exempt or inactive licenses, so it's pricey and it takes some time. However, much easier to do that than try to reapply after you've gone on to one of these other status areas. It's much, much easier. Now, this was just mentioned, the licensing boards don't ask. Credentialing bodies do, meaning hospital credentialing, practice credentialing. They're going to want to know how many patients you've seen. People who give you companies that give you liability coverage are going to want to know how many patients you've seen and what your practice is. So you may have a license, that doesn't necessarily mean that you can be credentialed. However, the credentialing process, although onerous, is easier than a relicensure process. Usually if you've been out for a while for as long as you're licensed from a credentialing standpoint, the hospitals may give you a practice monitor or a preceptor for a few months to make sure you know what you're doing and you're good to go. From a liability standpoint, the insurance can be expensive if you haven't practiced for a while, but gradually as you get further out and they see that you know what you're doing, the prices will come down. So that's a little bit dicier, but they're very separate issues. So who cares about this problem? Well, actually, obviously we care about this problem, especially female physicians, because this is the group that's primarily being impacted. But also the state medical boards and what's called the Federation of State Medical Boards, so sort of the Uber group for all the federation, for all the state medical boards is interested in this. The state medical boards truly are a federation, so every licensure body for every state has a different set of regulations and a different set of state statutes with which to work, which is what makes this challenging. But the state medical boards are very interested because we're trying to figure out how to make these definitions. The other place where this is going to be challenging is there's a lot of discussion nationally on what's called a state licensure compact. Have you guys heard of that? I'm not sure if that's gone anywhere. So you've heard a lot of discussion about should we have a federal medical license. Lots of pros and cons of that. That's probably not going to come to fruition. There's a lot of opposition. It's not the licensure part that's the challenge, it's the discipline part. So if you have a physician who is having issues and they either need remediation or substance abuse rehab or something, there isn't any federal entity that has the ability to find them and get them into the appropriate program. That comes from a state level. How does that happen? That comes from investigators and physicians and a lot of people working at the state level to make that happen. Who pays for the attorneys and the investigators to make that happen? That's funds that come from your licensure fees. And so that's why we hear a lot of opposition to federal licensure. It's not the licensure, it's the other side of licensure, and how does that happen? And nobody's figured out a way to make that happen. But to facilitate practicing across state lines, there's a thing now, it's called a state licensure compact that's being introduced in about 14 different states right now, and introduced in their legislature. The compact is to address issues where you need to work across state lines. So telemedicine, telemental health, telehealth, pathology, with pathology groups now being consolidated, and you look at pathology slides across state lines. If there is a disaster and you need to work across the state line. You know, when we had Hurricane Katrina, a lot of physicians went down there and they became the SUVs, the semi-known volunteer. They were showing up. They weren't licensed in Louisiana and couldn't do anything. Locally, we had the the tornado in Joplin, Missouri. Joplin sits on the line between Missouri and Kansas. Kansas patients in southeast Kansas went to Joplin for their medical care because that was the largest regional medical center. Once St. John's was wiped out, their physicians had no place to practice. Their physicians couldn't drive 10 miles into Kansas to practice because they didn't have a Kansas license. So that's where we're looking at how do we facilitate cross-state licenses. So the compact is analogous to a driver's license. You have a license in one state, every state in the country acknowledges that license and will abide by that license. The state licensure compact concept is you get licensed in one state as long as you don't have issues in that state. Other states that sign, not all states have to sign on, but if they sign on to the compact, they will honor that license. Well, when every state medical board has a different definition of who can get a license, who can come back into practice, what training you need, that gets to be very dicey. So in theory, you could be in a state where you're only out 12 months and you need some sort of program to get back into medicine, next to a state where it takes 10 years before you get back into medicine. How do we make those two talk to each other? And so this is where this needs to be fixed if we're going to have cross-state licensure, because we've got to have some sort of regulation that's somewhat contiguous among all of the states. The federal and state governments are interested because they're really, especially the federal government's really getting into this compact licensure issue. Hospitals are interested because interested in reentry because they're, especially in the rural and remote communities, they need to bring physicians on board. There are a plethora of physicians out there who could come back in. The hospitals are interested in getting them back in. The public is interested in reentry, not only to make sure we have enough physicians, but also so the physicians are appropriately trained. Yes?
And I want to add that the AMA is very interested in having numerous conferences about it, both at interim and at annual, because some of the issues that the AMA is involved in is in trying to maintain your physician integrity.
Yes.
And now there are a lot of groups of nurse practitioners, advanced nurse practitioners, who are trying to inroad and to be practicing autonomously without a doctor over them. And we know the training is so different between nurses, no matter how advanced the degree is, and doctors. And the thinking and seeing the whole issue that doctors see nurses are trained to think along one algorithm is actually the patient damage is happening by that. So AMS is really buying into this and is very active in trying to allow physicians to come back in, because the argument in allowing nurse practitioners to practice alone is, oh, we don't have enough doctors, especially the hinterlands, as Kimberly is talking about. So there's a lot going on, even in terms of our own political organizations in this area.
Thank you. I appreciate that. Always good to hear from the AMA. AMA is extremely active in this issue, and also from the state licensure compact issue. And you're right, in states like mine, which is 90% rural or remote, when the hospitals don't have enough primary care physicians, the APRNs are jumping on that, and every year for the past 5 years have put in legislation to allow them to have independent practice, and that was defeated again this year. But as Nancy said, that's the argument, is we don't have enough physicians, so we're going to fill the gap. Well, if you look at the physicians who have come out of practice, especially women, we probably actually do have enough physicians who have the degree and have the training. We just need to, A, get them interested, and B, figure out how to get them back in the pool. So why is this such a hot issue now? Well, again, this has been discussed over a decade, so it's not really now. It's just that it's ramping up. But more of an issue now because of the economic downturn. A lot of people who thought they were close to retirement, maybe took early retirement, are wanting to come back into practice because what they had for savings for retirement just isn't there anymore. And so they're wanting to get back into practice, so that's a little bit more men than women. increasing public demand for accountability, and so if the public wants to make sure that the physicians out there are qualified, we want to make, we meaning physicians, want to also make sure that the physicians are qualified. We have a responsibility to all of our patients. But probably the biggest issue right now is the physician workforce shortage, and we're facing a looming shortage. If you look at the AAMC data from this year, the projected shortage by 2015 is anywhere from 46,000 to 90, or by 2025 will be 46 to 90,000 physicians. So there's a huge shortage. That shortage is in primary care, but it's also in the medical subspecialties, in general surgery, in the surgical subspecialties. Everyone is seeing a workforce shortage that somehow we need to address. Now, the issue with the difference between 46,000 and 90,000, that's a lot, and it all depends on which modeling you use. If you assume that APRNs may have more independent practice and take up some of the spots that physicians would have, if you assume that everyone that will come in through ACA actually will. And always the issue is, what do we do with the millennials that are coming out? Are they, with the increasing push for work-life balance, are they going to retire earlier or leave practice earlier? Or because you're accruing more debt, are they actually going to stay in practice longer? And we don't know, and that's actually where the big divide is what happens to the millennials. But whatever modeling you use, it does not even begin to keep pace with the people that were turning out of the GME programs. So the increased number of physicians that we'll need is up somewhere around 17 to 19% over what we have. Best case scenario, continued funding with GME, that'll increase by about 11%. So it's going to be an increasing gap. So that's why the push now, especially with ACA, is where do we get all of these physicians? You can, again, we can increase a medical school class. Medical school classes over the past decade have increased 30%. That's great. GME funding hasn't. So now you've got all these people that are coming out that have medical degrees. They can't get the GME training they need to go into practice. Now you can do what some states are doing. Missouri did last year, we're doing this year. In Kansas, of giving someone a license to act as a physician extender. Missouri, it's sort of in perpetuity. In Kansas, they can get it for 2 years and then need to move on. It gives them a job, but they're still not in GME training. So the GME, if GME funding gets better, that's great, we'll turn out more physicians. But if you really look at the physicians that we need that already have the training, there are a lot more people out there, especially women, who already have the degree, they've got the experience. It's going to be faster, easier, and cheaper to get them back into the system than to start de novo with adding more medical students to the pipeline. So that's really the interest. That's, again, another area of interest in reentry is you've got a workforce shortage, you've got people who are trained, how do we get them back into the system?
Just a question.
Yes.
How many people are you exactly talking about when you say there's these people out there?
That's the other big question. I said you'll hear more questions than answers. We don't know. There's no national database. There is no way to know how many physicians have retired, how many are semi-retired, how many are inactive. It was a big survey that was done of AMA membership in 2011, which had okay data, but they only had about a 30% response rate. So you don't know how many are out there. And that's part of the issue is how do we track them down? And then how do we, if they're retired, great, but if there is any interest at all in getting back into medicine, how do we kind of push that along? And we don't know. The only data that we sort of is a sort of a large extrapolation from Arizona. They looked at their licensure and looked at people between license applicants between 2003 and 2006. Based on all the little extrapolation, they thought about 1.5% of the physicians in their state wanted to transition to active practice. And so if you extrapolate that, that's about 10,000 people in the US every year who potentially could go back into active practice. What we don't know from that is that there's no definition of how long those people had been out of practice, if they needed any reentry program, any training, how much it cost. And that's a huge extrapolation, taking Arizona to the entire country. But that's, if you hear that number, and you will hear that number when people talk about reentry, it's 10,000 physicians every year in the US, maybe plus minus probably quite a lot, though we don't know. But that's something else that we need to track, and there needs to be a better way to track that. Why do people leave practice? What is the off-ramp? What gets you out of practice? Well, as we discussed, there can be a health issue, and it may be something short-lived or not, and hopefully short-lived so that you can kind of get on with the rest of your life, including your practice. Substance abuse, an uncommon reason to actually have to leave practice. Usually that's something that can be remediated and keep someone in practice. Family needs, and family needs, whether it's a family member with a healthcare issue, if it is a young child that you're trying to raise. One of the biggest issues is burnout. And I would actually say personally from a female physician, those two, for some people, is linked. You only have so much time in your day. And so if you're trying to take care of the family and raise the kids, no matter how much your spouse or significant other is trying to help with child rearing, you're still doing the vast majority of it. So between that and work, eventually there's only so much you have to give, and eventually you reach burnout. And that's a, bless you, not an insignificant reason why people are leaving practice. A few will also leave for career change just because they want to try something different. Burnout is a huge issue, again, among physicians, usually correlated with high stress and low personal autonomy. As we're seeing more consolidated healthcare systems and we're able to decide less and less about what we do in our practice, this is probably going to be an even more significant issue. I was going to show you the lovely burnout and work satisfaction by specialties, but it's actually kind of depressing. So if you look, though, at people who leave practice, again, it's usually the vast majority, or not the vast majority, but the majority of people who leave are male, and it's usually to retire. But if you look at the younger group, it's usually women, and again, for different reasons. So there's a group or organization in Denver that's called CPEP that I'll be talking about later. It's the Center for Personalized Education for Physicians. It's one of the reentry programs. They looked to see why the people that were in their program that wanted to get back into medicine had left their careers initially. And again, this is a small study. There are only 62 people in this study because we don't have any national databases to find out who's inactive and why they left, and what we can fix. But looking at their 62 people, about a third left because they wanted to care for family members or needed to care for family members. Almost a third had a personal health issue. About 15% left because they were going for an administrative position, and 5% left because they were going into a non-medical career. If you look at it by gender, however, men were somewhat more likely to leave practice to pursue an administrative position. So for men, it was a change in career, change in administration, plus minus staying in the medical field, but it was career-based. For women, it was more family-based, and women were much more likely to leave because of family issues, much more likely with a P of 0.0001. So it's actually, so the women are leaving because of career or family issues.
Excuse me, but
yes.
What about financial reasons? Maybe women aren't as good as men at demanding payment, things like that.
And that's a good point, and that's another one of the things that I'll bring up. There actually has been a survey, and that's from the AMA database, that looked at why inactive physicians were inactive, whether they stayed inactive or they had been inactive and had re-entered practice. Financial issues were important, but significantly more important for male physicians than female physicians. Even in that study, it's child care and family issues that comes to the fore. Men is more what was described as practice hassles. So it's the paperwork, it's the financial issues with reimbursement, it's lack of autonomy in your practice. Although that's an issue for women, for a lot of the women who've gone inactive, that's really not the primary reason why they've gone inactive. Okay. So once someone has left practice, why do people come back into practice? Well, again, so financial issues, that's one of the things that's brought up, that there are issues with finances that brings them back into practice, responding to a community need, wanting a new challenge, missing colleagues and missing their patients in practice, and too much free time. I love that one. I'm waiting to find the person among us that actually has too much free time, but okay. And again, the AMA study, which happened in 2011, actually the study was through the American Academy of Pediatrics and was funded through the Women Physician Congress of the AMA. There was a grant funding for this project to survey the members. They also surveyed people that were either still inactive or inactive and re-entered. The things that were brought up in that survey: why were you wanting to re-enter? Why had you re-entered? Why were you thinking about re-entering? Change in personal situation. So again, the kids are growing up, or the sick family member is better, or that's no longer an issue. availability of schedule flexibility, financial need, and again, missing patients, missing your colleagues. Interestingly, the hassle factors were brought up much more commonly among the people that were still inactive but thought about entering practice than those who actually had. So they all thought that the hassle factors were a problem, but those that went ahead and took the step of going back into practice thought they were less of an issue. So whether it was less of an issue because they'd figured a way around it, whether they had practiced previously in a time it was less of a problem, whether they'd been in practice the second go-round a short enough period of time that the hassle factors hadn't been much of an issue, they really didn't see that that was that much of a problem. For those reentering practice, there are gender-based differences, just like there are for people who leave practice. Again, the same survey of the AMA of those either inactive and now reentered. Women much more likely to reenter practice if they have availability of flexible scheduling because they miss their colleagues and their patients or change in family circumstance. Men reported they're more likely to enter practice because they saw this as a new challenge. I think these are the guys that had too much time on their hands and wanted to do something else. Probably not participating so much in childcare, I'm gonna guess. Again, we don't know how many people are able to reenter practice every year. We talked about perhaps 10,000, but we don't know. When you look, again, and the reason I use CPEP, the Center for Personalized Education for Physicians, I reference their data because A, it's the only data that's out there, and B, this is a group that we use for the physicians in Kansas. When you look at people who have gone through their reentry program, it's about equal numbers of men and women. The difference being men have an average age of almost 58, women have an average age of 48. So when you're looking at longevity of practice, once you get back in, women leave earlier, want to come back when they're younger, and so more likely are going to have a longer period of time in which they're going to practice. So again, why, if we're going to address workforce issues, really need to tap into the female physicians who are out there who are inactive because they are going to be younger and hopefully practice for a longer period of time. So what is the reentry process? And again, I had no idea what this was until I got on the board and was totally baffled by some of the regulations. If you look at all the regulations for every state, for all those 49 states that have something, there is either mandated or discretionary assessment of competence, meaning after you've been out of practice, the 1 year, 3 years, 4 years, 10 years, whatever your state statute says, you either have to or you can at your discretion assess the competence of somebody who's applying for practice. So my recommendation is before you leave, again, plan your career. If you're going to leave practice, find out what the statute and regulations are in your state on what you need to do to get relicensed if you're not planning on maintaining your license. Once you've had this assessment, there may be a monitoring period afterwards. It may be that there's an assessment and they think you're good to go. It may be that you have some knowledge deficits and specific educational programs are recommended. It may be it's education and you really need to have a practice monitor just to keep an eye on your clinical skills for a period of time, 6, 12 months usually. On occasion, I've been on the board 7 years, I've only seen this come across once. We had a evaluation that came on one applicant last month who said, no way, needs to go back to a residency program. Fortunately, that doesn't happen very often, and that was problematic. Yes? Somebody had a question? No, okay. So the issue, though, that you have is what happens when you've been evaluated, you've had your competence assessed, you've got your whatever CME program they've put together for you, and you're going to go back into practice with a practice monitor. That's where things get a little bit dicey because the vast majority of state medical boards will see that as a limitation on your license, i.e. you don't have a full active and unrestricted license, excuse me, because you've got to have somebody there who's checking your charts or seeing patients with you or whatever mandated supervision level you have. What happens if you have a limited license? What does that mean? That means that's a disciplinary action. It's the same disciplinary action if you had a practice monitor because you've got a substance abuse issue, you have a disruptive behavior issue, you're having issues with liability coverage. Unfortunately, most of the limited licenses were all kind of grouped together. And so no matter what the issue is, if there is a limitation, that's a disciplinary action and it's reportable. That's a problem. So you're having people now who want to come back into practice but are having that action being reported to the National Practitioner Data Bank simply because they want to come back into practice. And that actually is one of the stumbling blocks that I've seen of getting women, especially back into practice, is going through all of this and then realizing not only is this going to be reported, but if you have a limited license and you have a level of practice under a monitor in which you can bill, if you're 100% monitored, you're just like a resident and you can't bill. But if you're seeing patients, the monitor's just there for backup or assessing things retrospectively, a lot of times you can bill. A lot of insurance companies will not contract with a physician who has a disciplinary sanction on their license. So you're not going to be able to bill. So you've been out of practice for a while, you've paid a lot of money for your CMEs and your reentry, and you still can't make any money because you can't bill. So this is a problem. So again, more questions than answers to a great degree. So some of the questions. Again, how rapidly are clinical skills and knowledge lost? We don't know. If you have someone who wants to come back into practice as a state licensing board, how do we know that you need remediation? Don't have a clue because we have nothing on which to go on. You haven't been seeing patients. What types of remediation are effective? Is online CME okay? Do you need to do live CME? Do we need to actually watch you with patients? Don't have a clue. How do we then adapt to this diversity of the needs? So when someone needs some sort of competency evaluation to be somewhat objective, they are sent to reentry programs, and there's 7 of them in the United States. The CPEP one that I mentioned in Denver, but they're also in Albany, New York, Philadelphia, Madison, Wisconsin, Portland, Oregon, San Diego, and Los Angeles. There is no national database for these. There's no national repository of contact information. There's also no national curriculum. So they all do something a little bit different. There is no standardized way, there's no standard thing that any of them put you through as far as a test to let anybody know that you're competent. So nothing that they do is standardized. Yes, ma'am?
I just asked, what about the specialty board maintenance of certification programs, which are specialized?
Yes, they are specialized, and that's something that will help. And so those are the kind of thing, and we'll talk about that in a little bit. No, that's okay. No, that's fine. It's a good question. That's the kind of thing that's going to help. And that's what we look at overall. So that's why it really can't be a cookie cutter process. We have to go through as a medical board, have to go through every applicant because there are things like that that are incredibly helpful and tell us more than any of these programs can. If we send applicants to a program, it's comprehensive. There's a cognitive function screen. Thank you very much. They go through your past medical history, especially if you had to leave for health reasons. You do clinical interviews. They'll do sort of an oral exam, simulated chart reviews. So you see a standardized patient, and then you write the chart. And so it's not only what your diagnosis is and your treatment plan and your understanding of that patient, but what are your documentation skills. Potentially put you through a written test if there are significant concerns on your competence. The standardized patients, the test, and everything that's done in this is they try to tailor to what your intended practice is going to be, or that gets a little dicier for people that are technicians, as Nancy mentioned earlier. If you're based primarily on your technical skills, if you're a surgeon, there are ways of doing it, but it's not all of that. It hasn't been around all of that long. Once the evaluation happens, there's a reentry plan. It may be, hey, you're good to go, not a problem. It may be that here's some CME, this is what we'd recommend. Again, CME with monitoring, 100% monitoring, and kind of have to take that into consideration. So once you go through that, and you've gone through that program, you go back to your state board. Hopefully you finished your CME, and again, you get to the issue of what do you do with the license. And this is something where, again, if people want to be activists and try to affect change, this is one place where one can affect change. If in your state, somebody who's in a monitoring program because of reentry does have a limitation on their license, there are ways of fixing that. And we fixed it in Kansas last year through the legislature, and that'll become effective July 1 of this year, in which we have a new category of licensure that's called a reentry license. For reasons that are somewhat unclear to me at the moment, my goal during my presidency of the board was to rewrite all the statute and regulation for every licensure category. God bless the attorneys that worked with me on it, but ours were written in 1957 and last modified in 1977. Things have changed in medicine since then. And one of these is the reentry license. And so we were the 5th state to have a new statute and a new category of licensure that's called a reentry license. What that reentry license states is it's still, for us, the 24 months out of practice before you need evaluation. They still need evaluation. They may need monitoring. It's the same level of patient and public protection, but they're given a special license that is non-disciplinary. It is non-reportable, so they can do all of this, still contract with insurance companies, don't have to worry about the National Practitioner Data Bank, and it's one less hurdle for people to have to worry about and to try to overcome when they're trying to get back into practice. Ours is good for 1 year with a potential renewal for 1 year in case you've got a huge amount of CME and you can't get it all done. We're giving you an extra year to do it. So that's something where if we could get more states on board with this, this would be incredibly helpful to get people back into practice. And also to let people know in your state that this exists if you do have the monitoring issue in your state, because most people haven't heard about it. I hadn't heard about it until we were starting to have issues. I had no idea that just reentry medicine was a reason to have an alert on your license. So what are some of the barriers to reentry? Again, it's a licensure issue. We find that more people are reporting that there are barriers to reentry who are thinking about reentry and haven't, than who've actually gone through the process. So it seems to be more daunting than it actually is, although it's still daunting. What are some of the issues? How do we, if somebody does need to be monitored or proctored for a while, whether again that's retrospective chart review or one-on-one real-time evaluation, how do you find them? This is not something that people are necessarily going to jump into because of a thing that's called vicarious liability, i.e. if the person going back into practice has an issue and there is an issue, there's a standard of care issue, if you are the supervising physician for that person, you may also be liable. There are some states like Kansas that have vicarious liability legislation. That means that only the person doing the act is liable, but that's not true for every state. And so that's something that kind of turns people off on doing the proctoring and monitoring. If they're going to be responsible for what somebody else does, especially when that somebody else probably can't bill and can't bring money into the practice, that gets to be a bit challenging. For those who actually need more intensive educational experiences, i.e. mini residencies, where do we put them? Because residency programs are not exactly flush with money. There's only a certain amount of GME money and there's not nearly enough for what we need to do. So if you have people coming in who don't need to be there for the entire residency, but maybe need 6 months, 12 months to really get their skills brushed up and get back up to speed, how do you find the residency program? How do you get them mixed into that program? And who's going to pay for it? There's no money in the GME system, so typically these are self-funded. Not that people are having to pay their own living expenses while they're doing this because there's no reimbursement and they can't bill because they're technically a resident and under 100% supervision. So it gets back to then, where do we define our educational home? Is it in our subspecialty groups, our state medical societies? Is it in the local academic health center? And this is another area where we really need to get the academic health centers engaged in this process, because this is something we can probably figure out. We just need to know it's an issue and need to talk about it. And then the big area that we hear lots of complaints about is the cost. This stuff is expensive. It's not just that you've had time out of practice without being able to generate an income, but if you're going to one of these reentry programs, looking at them, again, I know CPEP the best because it's what we use. Their cost is anywhere from $7,000 to $20,000 for this reentry, because it's not just doing the assessment and taking the test, but it is the follow-up with them, and they do follow-up chart reviews in the CME. You also then have to pay for your living expenses while you're doing all of this. This is not a cheap process. Interestingly, for the people that go through this process, another piece of data we don't have. We don't know how many people who actually, we don't know how many people complete the process, but B, we don't know for those who complete the process what they do. If you look at the limited data, again from CPEP, if you look at the groups that they have come through, the people that score at the lowest quartile on their exams, about 25% of them will actually eventually get an active license. If you look at the upper quartile, about 75% will get an active license. So somewhere about 2/3 of the people that complete their program will get an active license. We have absolutely no data to know what it is that they do with that license. So one would think generating that amount of debt that they're going to go into practice, but we don't know. And that's another area where we need to actually keep track of these people so that once they're licensed, we can get them into the areas where hopefully they can have an active practice. And something that Sarah Lynn Marks suggested over a decade ago is having a federal program where there will be money set aside where this could be paid for, but then you're going to give back in an underserved area or some other health clinic where there is need for physician care. And that's something that would be a way to look at this. Some hospitals will cover the cost of this as part of recruitment. They also will very gladly at times provide you with a practice proctor or monitor if they really, really, really want you in their hospital. Where that becomes a little challenging is if there's going to be any bias or conflict of interest. If they're going to pay for everything and provide you the monitor, if they want you that badly, how objective is the monitoring? And that can be questionable. So you ask about board certification. Is it sufficient for reentry? No, but it helps. So when you're looking at levels of competence, maintaining board certification is a great way of doing that. And actually I can't speak for our board, I can't speak for all the other state medical boards, but if somebody comes through and has maintained their board certification, that is extremely helpful because it means you not only have the knowledge base, but you've got the interest to be willing to do that and keep up with the CMEs to be able to do that. And that does speak much more specifically to your practice. It doesn't mean that more education wouldn't be required, but it's extremely helpful. Unfortunately, for some boards, you need an active license to maintain certification. So that can be a bit challenging. And again, my plea to keep your license active. Okay. So as I said at the very beginning, this is about licensure. That's different from credentialing. Every hospital and practice is different. It's a long process. So if you're going to go out of medicine for a while, you're thinking about coming in, start the credentialing process when you're trying to apply for your initial reentry license because it can take a long time to get everything done. And they may complain because you don't have a license, just let them know it's coming somewhere. Liability is also, again, a different issue. If you've been out of practice for more than 2 years, most organizations that cover liability insurance will think that you're going to be at higher risk. You may not be able to obtain coverage. You can obtain it, it may be more expensive if you're involved in a reentry process and you have a monitor. Again, in most states will have a limited license. That also is going to hike up your liability coverage, but once that monitoring goes away and you have a full and active license, your liability coverage rates go down to what they would have been without that. Okay. So I guess in summary, multiple things. One, plan ahead. Again, think of this as a highway. You've got a map. You may not know where you're going to end up, but at least have some idea of what the roads are and where you're going to go off and back onto the road. Understand your career trajectory. If you are going to take some time off, much, much easier to maintain your certification and maintain your licensure. Find out from your state what your licensure status is, what the different licensure categories are before you ever leave practice, and find out what their requirements are for you to be able to come back in. How long are you off? Do they have a definition of active practice, which I'll guarantee you they don't because nobody does. What they do for a reentry plan. Do you have a restriction on your license? Know ahead of time what you're getting into so you can make some plans. During your time off, keep up your CMEs. That's also incredibly helpful. Using only the current evidence-based sources, not just stuff that's online. So, good CMEs, however you want to get them face-to-face, online, doesn't matter. Keep up your CMEs. Try to keep track of them as you do them. It's frustrating to try to go back and recreate 3 years worth of CMEs and find all your certificates, so keep up with them and keep track of them somewhere. I would just recommend not trying to document more than 24 hours of CME in one day. We've had people do that. I will tell you, not to be biased, but it's all been male, where you're looking at 36 hours of CME on a given day. I'm so excited. I finally found the person who's found a way to extend a day to 36 hours. It's like, yes, that's what I needed. Got to be a little careful with that because that doesn't always look so good. Find ways to participate in educational opportunities if you've got a local residency program or a local medical school. Go in and teach, precept, run small group discussions. That all shows us that, when you're applying for license, shows us on the state medical board that you're maintaining your competence because there is a school of medicine that has given you their blessing and is allowing you to teach. So that speaks to the intellectual competence as far as the patient care, the documentation, et cetera. That's too where if you've got an opportunity to work, say in a free health clinic, something where it's not going to take a lot of time, not be too demanding, that too can also help because it shows that you're keeping up your clinical skills. before I came down and I was on this conference call and looking at licensure, I told them I was going to use this woman as an example. Absolutely perfect. She's been out for 4 years raising her children. She's maintained her certification. She's maintained all of her CMEs, and that means the number of CMEs for an active license, not the other licensure categories. Keep up your CMEs. Is teaching at the local graduate medical education program in her town and works in a free health clinic once a month. And that's perfect. She's done everything. And so yes, she's been out for 4 years, but I can't see how we're going to remediate any more than that. She's done all she needs to do. You don't have to do all of those, but some combination is really helpful. And then we get back to the overarching questions. Again, there are more questions than answers. As you saw, as we discussed from the AMA study, a lot of women get back into medicine because they found ways to have their career more flexible. How do we make careers more flexible so women don't leave in the first place, or men too for that matter? How do we improve work-life satisfaction? How do we prevent burnout? How do we somehow achieve balance so people don't want to leave medicine in the first place? Part of that would be expanding family-friendly policies, but how do we change the culture of institutions so it's okay to use those policies? A lot of institutions have them, but not a lot of people use them. And if you look at surveys, it's because they feel as though they're not supposed to, and they feel that they're being looked down upon because they're using a family-friendly policy. How do we change culture so that it's okay? And then questions for the system overall. How do we encourage physicians to reenter the workforce? If you've left, what's the carrot that's going to bring someone back in addition to the flexibility of the work hours? How do we get people back in? How many are reentering? We don't know how many leave. Again, we don't know how many reenter. We don't know once they reenter what they do and where they go. How do we keep track of that so we actually have a better idea of what it is that we're trying to fix? If we're looking at most 90,000 physicians that we're going to be short by 2025, we don't have a clue how we're reaching that number because we don't know how many people we're putting back in the system. Again, how do we define active practice? Not a clue. We don't know, again, how many go into the reentry programs. We don't know how many complete the reentry programs. We don't know how to assess, or we're not assessing for competence after they finish a reentry program because, as I mentioned before, there's no standardized curriculum and there's no tests that you take when we're done. So you finish the program, all they can tell us, they don't give us a grade. They tell us you either sort of knew it, you didn't know it, you knew it really well. Is that competent? I don't know. How do we define competence? How do we make the reentry process more visible and easier to navigate? How do people actually know, especially when you're in medical school, starting to think about when you're going to have a family? How do you plan this navigation? How do we decrease costs? The costs are prohibitive for a lot of people. If people that will, applicants that will come in and want to reactivate their license, they look into how much CPAP and some of the other programs cost, and they stop at that point because they don't have the financial reserves to pay for it. How do we help subsidize that? And then how do we encourage other states to develop the reentry license option so this is not punitive? The women physicians section of the AMA at the meeting last year presented a resolution that was modified but still ratified by the House of Delegates, that the AMA would work with the Federation of State Medical Boards to establish a definition of active practice of medicine as evidence-based, and would encourage each state which does not grant a full and unrestricted license to physicians undergoing reentry to develop a non-disciplinary category of licensure for physicians during the reentry process. So this is something that's been taken on by the AMA, it's been taken on by the Federation of State Medical Boards. We just need to push it through. So whether it's AMWA or the Voice of Women in Medicine, we've got to push this through because we need change. So thank you very much.